Well, good afternoon and happy Halloween, and welcome to our deep dive on community-based doulas. We're so excited to have so many of you join us today, and for the conversation that's ahead as we have talked with folks across the country about their efforts of what they would like to do to be able to better support birthing people. The idea of understanding doulas and community-based doulas has been something that's been top of mind. I'm Cynthia Osborne, and I have the privilege of being the executive director of the Prenatal-to-3 Policy Impact Center at Vanderbilt University. And we are really excited to be able to share with you today what we have learned about doulas as we've looked across the country, and to have an amazing group of individuals join us. I'm going to share my screen to begin some of the slides. And like I said, we are going to be joined by a panel of experts who will share their experiences and to really help us to understand not only what community-based doulas are, but the amazing impacts that they can have, but also to help us to navigate how to implement these initiatives in a way that actually promotes greater equity and birth justice. So we will be joined by Chanel Porcher-Albert, as well as Twyla Dillon, Tia Murray, and Adriana Jean-Louise, and very excited for that conversation. But before we begin that, again, I just wanted to review why we wanted to bring folks together, what we hope that you walk away with this. We really want you to have a good understanding of what it is that state policymakers have taken, the steps they've taken to date to support community-based doulas and to expand access to doula care, and what you would be able to do in your state to be able to do this successfully, and to understand some of the challenges and potential pitfalls of implementing these programs, and what states have dealt with, what they've learned, and how to avoid them as you roll out these programs. We also want to emphasize how important it is that we include the voice of doulas in the conversations with regard to policymaking and implementation, and that this isn't something that should be done separate from, but really integrated with those who will be providing services. And to understand that doulas are part of this comprehensive system of care to really support maternal health and birth justice, but that they alone are not kind of a magic bullet. They're part of this important system and need to be thought of kind of as a central role in that. So I want to just back up for a few minutes and provide an overall context before turning it over to the panelists. Many of you joined us a couple of weeks ago now, on October 12th, as we launched the updated 2023 Prenatal-to-3 State Policy Roadmap. And we added community-based doulas to the roadmap for the first time this year. And the roadmap provides evidence as to what the most effective policies and strategies are that states can implement to ensure that all children thrive from the start. And community-based doulas, the research has grown over the last several years to the point that we could add that to the roadmap. And they impact 4 out of our 8 policy goals. And I will go into a little bit of detail as to what they actually, what the research says that they have done, but they have been kind of an integral part now of our roadmap. And when I refer to community-based doulas, I want to make sure that everyone's on the same page of what we're talking about. And our panelists will go into a lot more detail about this. But these are professionals who provide emotional, physical, and informational support to people who are in the process of having a child. And it may start during the pregnancy. It's part of the labor and delivery process, as well as the postpartum period. But what's important about community-based doulas is that they specialize in this idea of culturally competent care. It really reflects the values and the lived experience of the folks that they're working with, and that this isn't some separate person who's coming in from the outside, but really someone who understands both language and culture and experiences that can be of greater assistance through this perinatal process. And like I said, there's been research that's been recently conducted that has helped us to understand the value that community-based doulas have in improving outcomes during the perinatal period. And there are 3 different types of studies that were done all around the same time. But what's important to understand is that although they have been sometimes in different settings, either embedded within a home visiting program or in a community health center or a teaching hospital, whether they've been in 3 different states, so Illinois, New York, and Michigan, they've all included primarily women of color in their studies and women who had lower levels of income or who qualified for Medicaid during pregnancy. And the kind of consistency in findings across the studies has been pretty strong. And like I said, they have added to our knowledge and understanding 4 of our policy goals. And so not only do they increase the likelihood that a person is going to attend their well visits, that they're going to, for both their child and themselves, that they're going to attend birthing classes, but importantly, they have important implications for decreasing the rates of preterm birth and low birth weight, for NICU admissions, and making it so that women are able to use epidurals to the level that they aspire to. And the research says that not only are they effective at important birth outcomes, but they also are lead to kind of increases in parenting behaviors that are more nurturing and that are allowing the mom to be able to engage with her child, and that they're participating in behaviors that are healthy for the child, including initiating breastfeeding and kind of feeding the child in a way that is more appropriate early on. And like I said, the research is really clear that community-based doulas are what is driving these impacts. The research on lay doulas is not as clear that it leads to the same sort of desirable impacts. And what we did was try to understand the ways that states are helping to support community-based doulas, and that they're able to both fund them by using Medicaid and to support the workforce through training or credentialing sorts of programs. And to date, there are 12 states that are using Medicaid to fund doulas, and there are 8 states that are supporting the workforce in other ways. Only 4 states are doing a combination of both of these levers. And there's a lot of activity, though, with more states coming on very quickly. But the range of benefits right now, even among those 12 states that are funding doulas, is quite large. And you can see that it ranges today from almost $2,000 to support doulas or reimbursed doulas in the District of Columbia, and only $450 in Nevada. Now, both Minnesota and Nevada passed legislation this last year to substantially expand those reimbursement rates, but still the variation across states is quite large. And also what is actually covered or expected in that reimbursement rate varies quite a bit. So it ranges from the number of visits from 6 to 12, whether these include kind of equal time and postpartum, or during the prenatal period, and so forth. So the variation across states in the types of services that are reimbursed is quite large. And what I was saying earlier, though, there's been so much activity this past year alone in supporting doulas. In 28 states, they've introduced legislation to support doulas in some way, either through Medicaid or through workforce supports and so forth. And 14 states actually enacted legislation. In our roadmap, we have details on what each of the states have done. And so if you're interested in going into greater detail to know what the states have both introduced or enacted, then I invite you, you can either visit it on our roadmap at the web address or the QR code to help provide you with more information there. And just in a short summary, 5 states enacted legislation this past year to provide Medicaid coverage, and Massachusetts and Connecticut are both in the process of implementing coverage. So although there are 12 now, Massachusetts and Connecticut will be doing that very quickly, and these additional 5 states will come in right after that. Of the states are already doing it, like I mentioned earlier, Minnesota and Nevada substantially increased their reimbursement rates. And in Oregon and in Utah, they've expanded their access to doulas for additional populations. In Oregon, it's for people who are in correctional facilities. In Utah, it's for public employees. And there are 3 more states that have enacted legislation to support their workforce. Both Colorado and Missouri have now supported scholarships and training grant programs. In Nevada, there's a program now to repay the student loans of doulas. So again, this is an approach, a strategy that is both highly effective and there's so much energy around. But we wanted to bring in the experts to have a conversation with you to really make sure that we're all on the same page when we think about what is it that we're trying to accomplish here, and in what ways doulas can do this, and what are the ways that states can think about supporting doulas so that they can do it even more effectively. And I'm so excited to be joined by Chanel Porcher-Albert, who is the founder and CEO of Ancient Song, and really a leader in birth justice. She has also been appointed by Mayor Eric Adams of New York City as a commissioner on the Commission for Birth Equity. And I recently learned that she will be running for State Senate of New York. So pretty soon it might be Senator Chanel Porcher-Albert. But right now, I want to turn it over to her, and she will speak for a little while and then introduce the other panelists who will come in and provide a conversation for you all. So again, thank you, Chanel, for joining us today, and I'm going to turn it over to you now.
Thank you for having me, Cynthia, and all. Hope everyone is well and centered today. I'm excited to be in conversation with you all. And so I hope that you are in a place where you are comfortable so that we can really have a great conversation this afternoon. I'm going to share my screen, so just give me 1 second. And I hope that everyone can see. Let's put it in present mode. Okay, so I'm going to tell you just a little bit about Ancient Song and the work that we do. And you've heard a brief bit about myself, but just to lay some grounding on understanding the role of the community-based doula and how they have been leveraged within our respective communities to really center hope and lift up birth equity. And so Ancient Song, we're a national birth justice organization, and our work has been grounded since its inception in eliminating the maternal and infant mortality rates among low-income Black and Latinx individuals. And we do this by really trying to center a quality of care where we're meeting people where they are, not where we expect them to be. Ancient Song, just to give you a quick backdrop, actually started in my home, in my living room, and it started out of a desire to really want to center individuals within their care, right? And to create a space, right, where I didn't see one. And so our commitment to addressing implicit bias and racism within the healthcare system is really grounded in providing evidence-based education in birth and reproductive justice, and advocacy, as well as training and direct doula services. And that has been our grounding, again, since our inception. And where we provide services, again, is within our respective communities, right? And I love Bell Hooks. If you have never heard of Bell Hooks is a social critic. Please look up her works. She has multiple books. But one of her quotes is, "Hopefulness empowers us to continue our work for justice, even as the forces of injustice may gain greater power for a time." And I think it's really important to understand that, because the work of a community-based doula is really grounded in understanding that we are not just in a community, but we are extensions of that community. We live, we work there, we are raising children there. Often times it's intergenerational. We have grandparents who have lived there for generations, right? And we're really trying to set a cascade for hope, right? In spaces where oftentimes there can be despair, and folks can feel like there is none. And so our work is grounded in New York City, as well as this is where we have sites in New York City and New Jersey. These are just some of the doulas that we have trained, who live and work within the community. And New York City as a whole, we're 8 times greater, more likely than our counterparts to die from pregnancy-related causes, right? And nearly 3 times more likely to experience severe maternal mortality and morbidity. So what does that tell us? That means that we are not centering some of our most vulnerable populations, right? We are not meeting them where they are. And so we have to find new and creative ways in which to be able to provide responsive care instead of reactive care. And I think that oftentimes what has happened is that there has been a reactionary feeling, right, towards addressing maternal health. In New Jersey, if you happen to be in New Jersey or around New Jersey, or you on the East Coast, New Jersey is ranked 47th in the nation for maternal deaths, right? And a mother or a pregnant person in New Jersey is 7 times more likely to either experience a near miss or some form of a pregnancy-related complication, right? And so, and for infants, it's over 3 times more likely than our white counterparts. And so we really want to find ways to understand that the landscape is different, right? When we're talking about New York City, we're talking about an urban environment. When we're talking about the landscape of New Jersey, we're talking about an environment that is really, the ecosystem is really spread out. We're talking about rural areas, we're talking about suburban, but also urban at the same time, right? So the approaches to care is going to look very different, and community-based doulas understand that, and they're really leveraging that in amazing ways, right? And they're doing that through connecting through service, right? Back to Bell Hooks, rarely if ever are any of us healed in isolation. Healing is an act of communion. And as the world shifts and changes and goes into this, these various different modes of trying to understand what is happening, right, within our own personal ecosystems, but also our expansive, and understanding that what happens outwardly also affects us inwardly. We have to understand that the healing process is not something that should be done alone, right? We can't do it alone. And historically, we haven't done it alone. And this is where the role of that doula comes in, to really leverage community in amazing ways, right? To lift up the emotional, the physical, perspective of what does it mean for me to center my body autonomy, myself, my family, as well as my community, as I am navigating through the intersections of my reproductive health access and parenting. Right. And so the community-based doula is oftentimes offering these direct services in ways that are addressing birth, postpartum, abortion, adoption, miscarriage, and stillbirth, right? Because we understand that the reproductive life course is not just concentrated on the episode of pregnancy, right? That it is very expansive. We're also understanding that all of the things that come up in our social aspects impact how we're able to birth, right? So we're taking into account substance usage, child protective services, right? Intimate partner violence. We're moving from a human rights perspective. We're looking at home visitation as a key lever, right, to bridging the gap in care, as well as the care that happens within hospital-based institutions. We're centering nutrition from a culturally relevant perspective and centering support, again, that is grounded in what does support look like for you, right? And so, again, we're not making any assumptions. We're not coming into a place and saying this is what you need, but we're asking people, what does this look like? What does this feel like? Does it have a smell, right? And we're being responsive to that and creating care plans on an active basis. This is just a picture of one of the giveaways that happens in New York on a monthly basis. We give out about 100 plus diapers, wipes, as well as we partner with a farmer to provide groceries, right? And so where it started out, where it was just providing it to pregnant and parenting families, is now intergenerational. And because we understand that there are grandparents who are taking care of children, right? They are not separate from the maternal mortality either. Oftentimes they become the holders of it, right? If we look at, for instance, Shamani Gibson and her mom, Shawnee is now, she's a grandmother, but she's also a mother, right? And she also is a part of the maternal mortality, right? Because she lost a daughter in childbirth. So we understand those connections within the community and how they're important to center, right? And it's grounded in the framework of reproductive justice, right? It's grounded in birth justice, understanding how race and gender identity and how individuals really just want to be able to make an informed decision about their care. It's very simple, right? We could talk about all the things, but it is really grounded in bodily autonomy, someone being able to center themselves and center their families in affirming ways and at the most sacred times of their lives. And this is where that human rights framework and really lifting up that moral compass of what does it mean for us to center norms that become standards of behavior, right? Our human behavior and how we interact with one another, right? How are we allowing people to have define self-governance for themselves, right? Over their bodies, that is without external influence or coercion, right? And so, your community-based doula is doing just that. They're understanding the barriers to care, which are cost and access, and there are also not enough of us to be able to do this work, right, in meaningful ways. And so we're constantly up against this roadblock that we're trying to address in real time. Some of the recommendations I have in regards to policy, and I'm going to make it very brief because the panel that is coming up, it's going to really expound on it, but increase Medicaid doula reimbursement to reach market value that accounts for cost of living. And so if we really think about inflation and the ways in which it's impacting individuals across this nation, that is something that we need to do. Provide community-based doula organizations with administrative fees to cover costs, right? So it's not enough to say, oh, well, you know what, now we have Medicaid reimbursement and, all is going to be well. No, right? We have to think about the inner workings of how do organizations flow, right? And what are some of the nuances that come up for them in order to be able to create sustainability. Community-based doula organizations should act as a clearinghouse and as oversight, right? And so what I've noticed that is missing within the process of talking about doula Medicaid reimbursement is really accountability measures, accountability to the doulas, but also accountability to the communities in which they serve, right? And so the community-based organization acting as that clearinghouse and that oversight is really bridging the gap and understanding that I see you, I hear you, and I want to make sure that the care that you are receiving is done in the right way, but I also want to make sure that the doulas are protected as they are driving that care. And we also want to codify doula services, right? And community-based organizations into law to provide sustainability within funding, right? I've been doing this work for a very, very long time and have seen the way in which funding cycles have oftentimes put people in a chokehold, right? Where you end up hand to mouth on a consistent basis. And so we want to eliminate that hand to mouth and really create a form of sustainability. And that can be done by really codifying doula services, codifying community-based organizations into laws so that that sustainable funding they know automatically it is coming, right? And so that they are able to plan accordingly and really serve their communities in amazing ways. All right. So this now brings us to the amazing conversation that we are going to have with our panelists. And I'm excited to be in conversation with them. And if you all could take yourselves off of, or bring your camera on, that would be great, while I reacclimate myself on the screen to be able to do the thing that I need to do. So I want to start out with Twyla. Twyla is from Health Connect One. Twyla, can you tell us a little bit about yourself and about your work within Health Connect One?
Thanks, Chanel. I'm happy to be with all of you today. My most important role is mom. I have 4 children, 25, 10, 7, and almost 2. I also don't sleep very much. Health Connect One is one of my children. I've been there for 3 years. They've partnered with Black, Brown, and Indigenous communities to train and advocate for community-based doulas, breastfeeding peer counselors, and perinatal community health workers since 1986. Our work has grown and expanded substantially to meet the needs of our doula partners, including the development of programming for hospitals and managed care organizations in support of doula work, partnership with other doula organizations, including SisterWeb, shout out SisterWeb's on the call, Chanel, Ancient Song, and a company, Care Doula, in the Doula Data Plus Compensation Consortium. We're working on several projects, including a time use study, which I'm going to talk about a little bit later, and the New Jersey Doula Learning Collaborative and other statewide initiatives.
All right.
But that's some of what I'm working on. I can share a little bit about New Jersey. The Doula Learning Collaborative that we're working on there was intended to support New Jersey-based community doulas to meet the needs of the community, as well as doula Medicaid reimbursement as it rolled out. This has involved community doula workforce, increasing New Jersey family care, Medicaid enrollment and billing support. And that part has been core to the collaboration with community partners to strengthen the impact of doulas in the collaborative. My favorite part of all of that is the community that we've built, right? And getting pushback, right? Hearing from the doulas. Doulas are not the kind of folks you will roll over. And that's one of my favorite reasons for doing this work. We need to hear our voices in all of this. And I'm not a doula, but I've been adopted as a doula and a midwife by a few people. But I'm happy to be here, and I'll hand it back over to Chanel. Thank you, Chanel.
You are very welcome, and welcome. So Adriana, tell us a little bit about your work in Massachusetts and your experiences with incorporating doula food feedback throughout your own policy making and implementation process.
Absolutely. Thank you so much, Chanel. So honored to be here and so thankful for this space. My name is Adriana Jean Lewis. I am the maternal health coordinator here at the Massachusetts Department of Public Health. My role is to lead aspects of the doula workforce initiative here at the Department of Public Health in Massachusetts. And I will say that, as previously mentioned, Massachusetts is in the process of rolling out a reimbursement plan for doulas, which is going to be housed by our Mass Health, which is our state Medicaid office. And they're very excited, and we've been partnering with them from its inception to ensure that this process has been as well informed as possible, including the doula voice and centering the doula voice as much as possible throughout that process. Here at the Massachusetts Department of Public Health, our work. One of the things that was, instrumental in really pushing this agenda forward is creating a doula partner advisory group. And our doula partner advisory group, or DPAG, as we lovingly call them, from its inception, which was about 2 years ago, has been very vocal about, and I love how Twyla phrased it, they will not be pushed over. And it's it's heartwarming in a sense, because as a doula myself, before coming into policy work for 7 years, I practiced as a community doula, to be on this side of things and to see the tension and to feel the tension, but also to understand both perspectives has, I think, offered a lens that is invaluable. And so it's been such a pleasure on my end, but also such an important role to be able to really center the doula voice, to offer a space and a place for them to come and to share without any inhibitions, their thoughts, their feelings, in real time, raw and unfiltered. From its very beginning, the doulas, we established a doula partner advisory group, and at first didn't have the funding to reimburse them for their time and expertise. And they were very vocal about, and obviously, it was obvious to me that, and to our department, that we would be remiss, we would be in the wrong, and it would be unequitable on our end to ask for these doulas' time, their expertise, their experience, for this commitment to the work and enforcing the doula workforce initiative without reimbursing them for their time. And so we were able to secure the funding to reimburse them for their time and expertise, and that has been made a marked difference. I will say that, without the reimbursement, doulas would be committed to this work and to making sure that doulas were reimbursed in Massachusetts. But with this investment, I think in doulas, we are building and continuing to build that trust, that transparency that's needed in order to push this work forward in terms of legislation. I will say, the legislative process is not one that's intuitive, right? Like, before coming into this work, it's not something that I knew or was very familiar with. And even in the process, I'm learning with the doulas as much as possible. So it has been, I think, pivotal for us to really take in their questions, their concerns, to read and understand the legislation as it sits, as it's been written and brought into different spaces as far as the legislative sphere, and to inform doulas as much as possible and the wider community as much as possible, so that when they're enacting and when they're pushing for this legislation, that it's as well informed and well-rounded as possible. And I know we're going to get into it a little bit further later on, but I once again am honored to be in this space and look forward to this discussion.
I just want to really highlight the fact that it takes a unique perspective. Like, you're coming from, and I don't think that people really understand it, when you are working with someone at bedside, right? And then you're able to incorporate that lived experience of what it really means to work with someone at bedside, to understand the institutional policies and practices that go on, and then to be able to apply that same knowledge to really inform how policy can shift and ebb and flow. That's a really, really unique perspective. And I think sometimes doulas underestimate themselves within the policy realm and how much they actually know, right? And really being able to lift up that. And so I just want to commend you for using that skill, right? And for understanding the value of, I tell doulas in doula training all the time, like, you don't just have to be a doula at bedside. Like, we need doula researchers. We need doulas who are data analysts. We need doulas who are in policy work. Like, we need doulas who are social workers. We need doulas who are in every aspect of care, because you're understanding what it means to be a touch point, but also the levers that it takes that are getting pulled at the same time when it comes to being an extension of community and the people that you're serving every day. So thank you very, very much. Tia, what's the vibe, Tia? Bring us home, right? Tell us a little bit about your experience in with Harambee Village and some of the barriers that you have experienced in Wisconsin.
Thank you so much, Portia. Harambee Village Doulas. My name's Tia Murray. I'm the founder and CEO of Harambee Village Doulas. We're one of the very first community-based organizations in our particular area. What's the vibe, Portia? I'm feeling like Wisconsin has been left out on the slides presented. And so I think that speaks to a lot of the barriers and challenges that we have come up against in our community-based doula work here in Wisconsin. We've been doing this work for 10 years now, and still feel like there aren't enough of our voices at the state level. It was interesting, in 2019, our state was deemed the worst in the nation for Black infant mortality. And that's really what woke up our state, if you will. But what we also discovered, we did a statewide doula survey because we got word that policymakers were getting excited about what Minnesota was doing, right, in respect to Medicaid reimbursement and some other states. And we were like, hold on, it's been done, but can we do it right? And can we do it equitable? And first of all, who are the doulas in the state? And what we discovered was that we didn't have a lot of community-based doulas. And those that we did have were trained at Harambee Village doulas, and there were a lot more lay doulas, if you will, some terminology used earlier. So we've done a lot of work since 2014 to not only continue to train more community-based doulas and increase that workforce capacity in the state, but also to be a hub for other community-based doulas, because this work is very challenging for many things that you all have shared and described, but also to work on that policy and systems change work that has to go hand in hand with those really good outcomes that we can support on the ground and in the community. And so that involves really pulling everybody together. It takes a village, and we are not the silver bullet, and really wanting to change that narrative around, if we bring doulas in, we're just going to solve all the problems. And so we really worked to make sure that we identified other leaders doing community-based doula work to be at the table with these policymakers and legislators, so that they could really understand and hear from those that are closest to the work. So we've come up against a lot of barriers. We don't have a very bipartisan legislature, which has been extremely challenging in having statewide impacts or changes. But we've continued to let them know that we will continue to find different ways to chip away at getting towards that overall state level change. And so what we've done, and I'm sure we'll talk about this more later, is focused more on sort of micro level policy changes in hopes that we can begin to build more of a ripple effect across the state as well. But so the vibe is we've been doing the work. We're glad our state is finally a little more woke, if you will, in respect to the work that we're doing, the value of a community-based doula and how that differs from your typical doula work. And that Medicaid can be an avenue for really sustaining the work that we do, but we must make sure that it's done right with the right people at the table and that the end result is really equitable for everyone involved.
Indeed, right? Because I know the Medicaid doula conversation, right? When you start to talk to state agencies, can start to become very bureaucratic. It becomes very nuanced. It becomes very systematic. And it's butting of heads, right? Because you're talking about care work, right? You're talking about service work to your community, right? And you're talking about systems level changes, and systems in and of themselves are not grounded in necessarily care work, right? They're talking about the functionality and the levers that need to be pulled in order to make something work. We're talking about how are you really centering people? How are you allowing them the full joys of what does it mean to center oneself, to center one's parenting, and understanding that that is a ever-flowing extension of community in real time, right? And that oftentimes can get lost on on deaf ears. And yeah, and you're in Wisconsin, right? And so Wisconsin is, I guess, for all intents and purposes, rural, right? We're talking about a rural area that oftentimes rural areas are always overlooked, right? They or the bigger states oftentimes get more of a spotlight in what does it mean, and then it sets the groundwork. And I think one of the things that people really to know is that when we're talking about Medicaid doula reimbursement, as you stated, it's not a one size fit all, right? And it really has to be done in such a way that is reflective of the community that's being served. And it needs to be revisited too. So just because it's just because it's happening and it's been put in paper on one time and one occasion, there needs to be this level of, as you said, Adriana, you all created this community extension, right, to give continuous feedback in a loop, having those loops be continuous and also inform when policy needs to change. as times are changing or the needs of the community change. And so that brings us into or backtracking a little bit and understanding that currently right now there are 12 states that currently reimburse for doula services through Medicaid. And more states are in the process of really like getting this underway, right? And you know, doulas understand that they function differently than traditional providers and are often new to the Medicaid space. Can each of you share 2 or 3 key considerations that state policymakers should keep in mind when introducing legislation and designing a program for Medicaid doula reimbursement services? And so, Tia, since we left off with you, we could start with you. I don't mean to put you on the spot, child, but
No worries, I knew you would. That's why I'm happy to be here today. But I think going back to what I was mentioning is that we can't have legislation and policy change around Medicaid reimbursement for doulas without the systems change, policies and legislation to go hand in hand, right? We can have it, but it's not sufficient, right? And it won't get us to where we want to be. And so I think we tend to compartmentalize those things and they have to go hand in hand. So those conversations have to be happening simultaneously. And in that doula legislation, I think there should be things that accompany policies and systems changes, right? And holding our healthcare systems and other systems accountable, because we are not the silver bullet. 2, I think really understanding the work of a community-based doula and how that differs from maybe your typical doula with a private practice. We have a lot of doulas with private practices in Wisconsin. And so there was a lot of talk about, well, how will we regulate them? Is DONA the golden standard for the training and those sorts of things? And so what we did is we decided to create a training and certification program that was much more responsive, at least to what we were hearing from doulas and community members and birthing folks, so that there would be an alternative option, 1. So I think really understanding the community-based doula workforce would be a recommendation and that differentiation. And then thirdly, as you mentioned, these cycles of funding, Chanel, I don't think that our state has yet recognized community-based doulas as an evidence-based practice in respect to home visitation or, you know, working with families in the early child field or the maternal child health field. And so oftentimes that federal funding trickles down to the same Title V programs. But guess what? We still have the same disparity, if not worse. Matter of fact, when I started this work 10 years ago, Black birthing folks, particularly Black women, were dying at 3 times the rate of their counterpart. Now it's 5 times the rate. So why do we continue to invest in the same models? Yes, they may be evidence-based, but we also know the evidence about community-based doulas. So I would encourage states to do their own local research on what's working in your very own backyard and communities. And that's another thing we decided to do, was begin to do some of our own research and work in partnership with other researchers and MDs who care about the work, understand the work, so that we can then demonstrate. We've had this literature for over how many years, but here in Wisconsin or here in Dane County or through the work that we've done, these are the outcomes that we're getting, such as increased breastfeeding rates at our largest birthing hospital, such as an uptick in women participating in telehealth hypertension programs in the postpartum period. So, you know, those are definitely recommendations that I would hope to see, particularly in Wisconsin, going forward.
Yeah, thanks. So I'm hearing really understanding the doula workforce component in the ways in which we are differentiating between traditional based doulas or private doulas and the community role of the community-based doula. I'm hearing divesting from models that are no longer working. And I'm using that word divest intentionally, okay? We are divesting from models that are no longer working to invest in community-based organizations who are really centering effective models of care within their communities. And, you know, I think that all of those are really, really key. And then also, like, when we're talking about training and we're talking about certification, looking at the needs of the people in which are being to be served, right? And so it's not it's not just based on this one size fits all type of model, but we're understanding that it needs to be culturally responsive. It needs to be intersectional. It really needs to really uplift a birth and reproductive justice framework when we're talking about the ways in which our communities are and their lived experiences need to be addressed in an active way. Twyla, same question for you.
Absolutely. I agree with everything Tia said. I have some different stuff. The strongest recommendation I have is to set a sustainable wage for your community, right? These rates should be for prenatal labor and postpartum and parts of that, if that's what makes sense for a particular community. And when the math is done, right, these state governments spend a lot of time doing math. When the math is done, the income should enable someone to live comfortably. I don't like the term livable wage, right? That doesn't sound appealing at all. Live comfortably and support themselves in that state or region. That's not the end point either. I mentioned the Doula Data Consortium and the work that we're doing there to better understand the time and effort required to drive these positive outcomes that doulas are leading to. We have value-based payment for other sorts of providers, right? Clinical providers. When doulas are really contributing in a way that's improving the bottom line for hospitals, they should be able to take part in receiving some of that income as well. So we need to figure out better models for that. Another recommendation is, and I think this is akin to what was mentioned earlier, but not to overregulate which models are approved, right? Doulas are going to doula, whether they're doing it under a particular umbrella of reimbursement or if they're doing it independently through sliding scales or for free, which they shouldn't be doing. But some people do because they want to support their communities. It should not be overregulated. There are several models of training that share core competencies and best support diverse communities. So really making sure that those models and the core competencies they're in are established. And that's what we're looking at, not necessarily this model, that model, and this model, but nothing else in this entire state. That does not make sense because new models are popping up all the time. And if they have what we need to support community members, they should be included. It shouldn't be this restriction, which could lead us down a path we shouldn't be going down, which is what's happened with our Black midwives, right? We have to be thoughtful to not recreate issues that we've had in the past. And we've talked about it. Chanel, I know you and I have spoken about it, figuring out, I know you already had a list, right? These core competencies. Somebody fund us to get together and do that, right? Like that's an important thing to do. That's an important conversation. And it's one of the questions in the chat. I've been paying attention to the questions and answers. The last thing I'll say, and it's not the last thing, but the last thing I'll say is to make sure that enrollment and billing processes are not overly complex. What are they talking about in DC right now? AI, right? We can do all these things with technology, but enrollment in Medicaid and billing is mind-boggling. It should be easier, and it should definitely be made easier for folks who are doing this work in community. And I just want to +1 on the divestment in models that no longer serve community. We need to ask community what they want, what they're comfortable with, who they want in their house, right? Ask the people what they want and give them what they want if you want to see the outcomes improve. Thank you, Chanel.
Give thanks, Twyla. So, I got to play it back, right? Because that's the doula in me that says I'm listening and I'm actively listening. We want to set a sustainable wage, right? So really looking at the data, looking at what is going on within the state, right? And lifting it up top tier, not to overregulate doulas and their work as they're doing it, right? And so, again, in the name of wanting to create mechanisms for accountability, we don't want to inadvertently push aside a whole population of individuals who are doing work, right? We want folks to be able to maintain their profession as something that is, again, ancestral and traditional, while also creating a pathway for professionalism that works for folks who are accepting Medicaid reimbursement, right? And I want to be clear that we're talking about specifically Medicaid doula reimbursement. We're not talking about the regular doula who just wants to do doula work. We're talking about for Medicaid doula reimbursement. And then also enrollment and billing should not be complex, but it should be something that is easily accessible. And so, I know what that process can look like. We're talking about a book that you have to go through, right, just through the state, but then enrolling with every single managed care plan, which can be a headache. And folks are like, I'm not ready. I don't want to do all of that. I just want to do this work. And that can cause people to become disheartened with the whole process, right? And not want to continue or we hear the other thing that gets whispered, like, well, see, they weren't really interested in this to begin with, right? When that's not necessarily the case, right? So we have to think about ways in which how we're, again, meeting the needs of the doula in exemplary ways. Adriana, same questions for you.
First, I just want to underline everything that's been said so far. It's as a doula, right, as a practicing doula, and also in this position, I think all the things that have been shared so far thus far have been central to what our concerns have been. So all that said, I think as a state agency, right, representing a state agency and with that hat on and that lens and framework on, I think some of my recommendations first was for other state agencies, for those who are working on this legislative process. And I said this before, but policy making legislation is not easy. It's not approachable. It's not intuitive. And the onus as a state agency is on us to educate, to really offer as much information as possible, and to go into the spaces that haven't been tapped into, right? And to go into the field and to go into the work and to speak with the people who want this information. And I think what amazes me about doulas and this workforce, as autonomous as they are, there's never a lack of there's always a thirst for more knowledge, right? There's always a thirst for more professional development, for more workforce development, and not just for themselves, but for the entire field, right? Like I've had doulas who've approached me like, I know 6 other doulas and we all want X and Y training. How can we make this happen? Okay. Right? It's always this mentality, and I understand it and I feel for it. And I think, you know, the root and the groundwork of birth work, right, and working in community maternal health before it reached, you know, state government has been this, it takes a village, it takes a community, and we're committed to our communities and to our villages. All that being said, right now in Massachusetts, and I think the same is across other states as well, the workforce, the dual workforce is very decentralized. And that therefore creates gaps in mentorship, in workforce development, and opportunities for growth in the field. And there are doulas who, and I mean, it's an unfortunate truth, who would like doula work to be their primary career and income source, but unfortunately have to be able to offer other things, or are taking this as a second and third job, right? Are taking on second and third jobs in order to really provide, to be able to do doula work, right, in a way that they fulfills them and fulfills the needs of their community. And I know someone mentioned this before, but also live, right, and be and take care of their children and pay for parking and all the things that come with being a doula, and all the other things and those minute details that aren't discussed, right, on a larger scale, that come along with taking on this responsibility, because at the end of the day, it is a responsibility. All that being said, so that's the first. I think that, you know, decentralization of the doula workforce has been and continues to be a struggle, right? Because as a state agency, there's not one centralized doula workforce or group that we can go to and say, hey, give us your thoughts and opinions, because there's so much stretched out, and there's such a diversity in terms of the offerings of the doulas, right? Like we have Boston Central doulas, we have doulas who are on the Cape and the Islands, we have doulas who are out west, we have doulas that are working within hospitals, we have doulas that are working outside of hospitals. There's such a diversity in the field that as a state agency, it can be difficult, right, to make sure that we're knocking on every door. And that's not it's our job to, it's our onus, we need to be doing that. But I think that more centrality in the doula workforce would be very helpful. The other thing that I want to mention as well is that as we seek legislative authority here in Massachusetts, so as the Department of Public Health, we don't have legislative authority at this point to certify or credential doulas, right? And so our Medicaid reimbursement is coming from Mass Health. They are doing that as an office, as an entity. So when we, you know, came to the realization, had an understanding that, okay, we have to be able to invest in this field in another way as we seek, simultaneously as we seek legislative authority, we approach the doulas with how can we best serve you? What can our focus be? Where can the dollars go? How do we best approach this? And one of the things that the doulas mentioned, and we're really, you know, I mean, there's a bunch of things, right? One thing that rings true to me right now, and is in my mind right now, is a conversation about doula hospital, integration. Right? And that we need to be preparing our healthcare system for the influx of doulas that are coming into these spaces, right? And there's a massive disconnect between the hospital healthcare system and the doula workforce. And how can we best approach this problem, right? And with our doula partner advisory group, of course, is central to doulas, but we also include representatives from ACOG, ACNM, birth centers, community health centers, policymakers, advocates, they're all invited into this space and into this forum to have real conversation and to really, I've had a physician in this group at one point said, I don't understand how the pay rate for doulas can be X and my reimbursement rate as a physician can be Y, right? That's a pretty inflammatory thing to say in a space with doulas. But we were able to have a real conversation about and change their thinking about and their understanding of what reimbursement is, the obstacles that doulas face, and the things that they're not taking into consideration that doulas have to consider every single moment they're doing their work. And so that was a great place to have that conversation and to really level set in a way that was informational, informative, and impactful. Because it wasn't just a conversation between the clinician and the doula, it was a conversation between an entire community that didn't understand and still doesn't understand, I think, the scope of doula work. And so our hat became, not only are we seeking legislative authority, but we're also acting as facilitators and educators, right? And how can we bring in other spaces this work and the concerns and the frustrations of doulas with our state agency hat and affect change? And so one of the things that we did was partner with our state PQC, which is called PNQN, the Perinatal Neonatal Quality Improvement Network, to leverage the existing relationships they already had with hospitals, right? Our PNQN is a massive force. They have bundles that are released every year. And I think they have like 5 bundles going on right now around hypertension and AIM and all these different bundles. And how can we leverage the relationships that we already have with PNQN, right? And the PNQN has with hospitals to introduce doulas into this conversation, right? So as a state PQC with their power and with the leverage that they have, I would urge other states as well and other state agencies to leverage relationships that are already existing and enter those spaces as a facilitator of education, because the doulas are not shy about speaking their voices, right? It's really getting folks to listen. And so how do we bridge that gap? And I'll pause there.
Give thanks. You said a lot, right? So we're talking about workforce development and ensuring that as doulas, like any other profession, right? As you go into a profession, you have to take continuing education credits. You have to, stay abreast of what's going on. Doulas want the same thing, right? They want to understand. They want to be able to offer a robust amount of skills to the community that they're serving. You're also talking about centralization of the doula workforce. So to me, my ears go, ooh, unionizing. What does that mean? Right? What does it mean for, hey, listen, let's talk about the realities, right? What does it mean for doulas in your respective states to either formulate co-ops or thinking about working with unions, right? Or developing your own union so that you can mobilize and strategize, right? And be able to really have that buying power that you need, right, inside of those bureaucratic spaces that oftentimes are not necessarily willing to hear, right? Because the conversation or the things that I have oftentimes heard is that, well, the doulas don't really know what they want. Like one doula is over here saying one thing, there's another doula over here saying something else, right? And so really having that centralized voice, that union and or that co-op, whatever works best for you and your respective community could actually be something that can really work. And then hospital integration needs to happen that really looks at best practices for what does that mean. One of the things that we were able to do at Ancient Song is we have a hospital-based program in New York City, in Queens, New York. And, the model that I developed was really focused on, I'm not putting doulas in a space where they're going to be harmed. Right. So I said, before we can even do that, every person that comes in contact with someone who is pregnant needs to understand the role of the doula, what they do, right? How they function. Let's talk about grievance processes. Let's talk about accountability to one another. So everyone from the admin person, the social worker, the CNA, the nurse, right? The midwives, residents, everyone needs to be trained on understanding what is going on in community. So an overview of that, but also really understanding the impact of the doula patient relationship, as well as the doula provider relationship. But then also creating a community advisory board, right? So that there's checks and balances, because you can't go into someone's community and just say, well, that's what you need, right? And so having that's not what we're doing. We're not doing that kind of thing, right? We are going to be intentional about creating relationships with those who are going to the hospital, right? So if that means that you have a population that maybe even outside of the people that you serve. I know for us, we had a huge South Asian population. We had a huge Spanish speaking population. A lot of our doulas were not within that community. They did not speak Urdu, Arabic. A lot of them did not speak Spanish. And so we were intentional about creating training specifically for them so that they could be trained to be able to serve their respective individuals who were coming into the hospital. So like thinking about pathways for that level of accountability, but also that's, I think what I want to point out is the importance of grace and being humble about it as well. Because oftentimes all of us, right, on both sides can go into stuff really supercharged and really like, yeah, we about to make this happen. Like, I need this for my community now. And others are like, listen, I don't know what all this is about, right? I'm gonna need you all to calm down and take several seats. And so we really want to have those intentional conversations, right? And level set before we even talk about just putting someone and throwing somebody in the mix of something, right? Because if we're talking about creating harm reduction for our community members and our doulas are also a part of that, then we also have to create that space for them too. And so I really appreciate you saying that, Adriana. What have been some of the limitations or the realities of policy? Because I think that we oftentimes will give policy recommendations, and so then doulas get hyped up and they're like, yeah, we only got to do this, that, and the other, and then that's what's going to happen, right? Not understanding like the levers that can oftentimes and the nuances can happen. So what are some of the, this is for anybody who wants to answer, what are some of the limitations that you have seen in the roadblocks, and how were you able to maneuver those levers, but also to get the doulas to understand the processes for those things?
So I think for me, one of the biggest things, especially doing this work in the New Jersey Dual Learning Collaborative, and then also working in a number of different states, the biggest barrier for this work has been extra bureaucracy. And I say that because it feels like sometimes navigating systems, wherever they are, like this is not specific to New Jersey, this is across the United States, in every state, federal government, everywhere you go where there's a system, there's some level of bureaucracy. And we know that folks need support, but navigating through that, I think Chanel alluded to this earlier, is fatiguing, right? And we know we don't have enough doulas as it is. So whenever we can shorten the path to a solution or a yes or a no sometimes is what you need to get to figure out what you do next, but not having to navigate through all those places and spaces, I think explaining some of that process to doulas, it can be frustrating, but it is necessary. One thing that has been really integral for us is, I'm going to speak to New Jersey, is having a champion, right? Somebody who is going to consistently say, okay, we're going to figure it out. And for us, honestly, that's been the office of the First Lady, because the Nurture New Jersey, that whole book that other states are trying to take on, whenever we've run into challenges, that's who we've kind of leaned on and said, okay, here's something that's been a barrier. Also, within every managed care plan, we've found somebody. It doesn't always work because those processes, Chanel ain't lying, it is a book, right? To get enrolled in some instances. And you have to do it in New Jersey in 5 plans, right? But finding someone within those plans, some of our partners and MCOs have covered the cost of training, right? For partners, including a stipend to go through training. So figuring out who your champions are and really making sure that you keep them in partnership. We've got funder partners. We've got Burke Foundation in New Jersey. So who are your partners? Who's going to be there? Who's going to stand up and say, okay, this is important and here are the reasons why. And they know it almost as well as whoever it is that's pushing that agenda does. Does that always work? No, because you still have to navigate bureaucracy, which is, to me, one of the biggest issues. But it helps to have a better understanding and someone who will stand with you as you have to take the unfortunate results of sometimes your really hard work. And I heard you loud and clear, Chanel, as you mentioned that union, and the word that nobody wants to hear, but that's important. It's important. That's why I do love the DLC, because it's important to have a body, right? A body that can speak on behalf, and hopefully in most instances with one voice or something that's at least an amalgamation of voices. That is very important. And that does not exist in all of the states where reimbursement is happening. And I think that that's a huge challenge, because there's nowhere to go, right? There's no one to talk to unless you're talking to government. So I do think that was a good outgrowth in New Jersey. We still have challenges, but it's good that it's there. Thank you, Shana.
Yeah, thanks. Tia, Adriana, would you like to follow up with that?
Yeah, absolutely. Yeah, I think one of the issues that I've we've been experiencing here in Massachusetts is a lack of, I'll say, of misinformation as far as a state agency, understanding state agency and the roles of each state agency, right? So, for example, the Department of Public Health and our state Medicaid office, Mass Health, are sister agencies, and there's some synergy that needs to happen in order for us to work, right, in this larger government body, but we are not directly responsible, right, or related to the work that one another does. And so I think that the misinformation piece that comes in oftentimes is that, I've had, folks come to me like, hey, I don't like that this is happening, X, Y, and Z is happening in Mass Health. And that's a separate agency. Although a sister agency, it's an entirely separate agency. And so I understand where your frustration is coming from. And I understand why, intuitively might think I'm going to reach out to the Department of Public Health because it may seem like, there's a hierarchy there. But in reality, right, it's more of an umbrella. And certain things that come out of certain spaces, there's more leverage in one office than there is in another. And I think that oftentimes, unfortunately, because there isn't that understanding of what state agencies and their different roles, that can be translated into misinformation and legislation as well, right? And things are getting written into bills that are directly opposed or opposite to what that specific state agency is designed to do, right? And so that being said, our state legislators, and I love how you, I think it was Chanel or maybe Twyla mentioned, reaching out to who your not superstars, I forgot the word that was used, but who the
champion is.
Champion, thank you. Oh my gosh, thank you. The champion might be, I 100% underline that and highlight that. And yes, reach out to your champions, but they are receiving information just as you are. They don't know everything, right? And it's important as we share information, as we kind of, divvy up tasks and things of that nature, that everyone has the same information and that it's correct information. And so that's one of the challenges I'm seeing. And the other thing I would mention as well is that we really need to, across the nation, in these conversations about doulas and policy and legislation, we have to be centralizing the doula voice. It blows my mind that there can be legislation written and things enacted that at no point throughout the process of legislation, whether it be a line written into that gives authority or power, was a doula or a body of doulas or consulting with doulas or conversations with doulas, that didn't happen. And so it's really, really important that we are not only bringing doulas to the table, but going to their tables, right? So that may be attending a meeting, that may be stepping into an uncomfortable space. And I will say, and it was mentioned before, doulas are not afraid to share their frustrations, respectfully. They're not afraid to share their frustrations. They don't care about, they'll point a finger wherever they need to point a finger in order to get an answer. And my mom has 7 sisters and they all have, voices. And so I'm okay with, a little bit of a raised voice. And I understand the tension and the frustration oftentimes that comes from this work, because it's not just one, it's a series of events. It's a generation of events. It's literally maternal mortality and morbidity at their heels every single day. So I understand where the frustration is coming from, but that misinformation and the lack of doula presence and voice in the conversations and in the spaces where they need to be happening and where they need to be present, not being present as a state agency, I think it's a grave oversight. It's literally the difference between success and failure when it comes to having a doula reimbursement.
Yes, indeed. So one of the things that I know oftentimes gets left out of this conversation, right, is talking about the ways in which, yes, there are some states that are enacting Medicaid doula reimbursement, but how is that also trickling into the private insurance sector, right? And what have you all seen? As well as how is it impacting government contracts or city contracts? Oftentimes, I've been in these conversations where people are like, oh yeah, we got this thing, we got all this money, and we can offer doula services. And then I'm like, okay, tell me about what you're doing. And they're like, well, there was an RFP, it came out, and I was like, oh no, that's not reimbursement. Like that's a program, that's an initiative that someone set out. So tell us a little bit about what you have seen in terms of first part of the question, the private insurance sector, when it comes to Medicaid doula reimbursement, the positives and the negatives, if any?
So managed care organizations, and this is what my experience has been in some of the work that we've done with them, they can pay for it if they want to, right? Whether or not it's in legislation in a particular state. If they want to pay for it for private plans, right? The commercial side, they can put it in there. They can put it as a value added benefit. So they make a lot of decisions based on what makes the most sense for the markets where they are and what their members want, right? If we're talking about the commercial side. So really being, they have more flexibility than we would think in terms of what they're doing internally, if it's something that they recognize has a need, right? And they want to invest in it. So I've seen a lot of variation there. I've also seen different kinds of applications, right? For folks that are working both commercial or Medicaid. So there's a lot of opportunity, I believe. I think someone put in the chat, like, what would it look like if that was something that was happening? I think if it's legislated beyond just what we're talking about, the Medicaid reimbursement side of it, if it's legislated to be something that's made available to anyone, right? Any pregnant person, if that's what they want, they can have access to it. That would be different, right? I think it's important, obviously, that we're starting where the needs are the greatest, but I would anticipate as time goes on and more information is made available, that there'll be a variety of ways in which doulas can be reimbursed, not just through this specific pathway or figuring out some philanthropic opportunity or direct pay. There was something else that came up in there about payment, right? So the fact that doulas can't necessarily survive, if you will, on the Medicaid reimbursement rate, right? And that there has to be some other strategy. There's a tool on our website, and I'll share the link, called the FAST tool. I think you've seen it as well, Chanel, that kind of shows braided funding and what that could look like. Doesn't mean that that's the answer. It's just a way to know whether or not you'd be able to survive if you had different sorts of revenue coming in. And the Burke Foundation and Rutgers helped to develop that alongside Health Connect One and the Doula Learning Collaborative. So I'll add that to the chat.
Yeah.
Thank you for this question, Chanel. I really do think, I mean, in our particular state, our private insurance companies aren't doing very much at all. We were approached by one of our largest private insurance companies probably over a year ago, and we're still in conversation around what could this look like. But I do think they don't realize that they're uniquely positioned to really set the stage, because we don't need state legislation or rule changing, right? For them to, they could make it happen, like Twyla said. And when you think about the nature of just how our economy works, it's about competition, right? I hate to say that, but if somebody can get it right, you would think everyone else would come along, right? And so our hope is that we can get a private insurer on board. And a lot of the work we've been doing, it has really shifted from the state legislator to more micro level, working with Medicaid HMO providers. We have so many across the state, and one in particular, Dean Health Plan, which is now Medica. We've developed this model of how we can bill them for our doula services outside of becoming, you know, a Medicaid provider and going through all the bureaucratic red tape. So I think it's setting a model and an example of how we can do that in other spaces. And what we've been missing is having the payers at the table, right? We can't also legislate or change policies without having the hospitals and clinic systems, as Adriana mentioned, and the payers. So they've been missing from the table. But once we began to engage more with the payers, we are seeing more of a sustainable avenue to really get to a model where we can cover doula services. I think, and this also stemmed from one of the things I think our state got right a few years back with a newer governor that came into office, was implementing requirements on those Medicaid contracts to cover things such as non-medical services, or whatever they call it, which include doulas and community health workers and those sorts of things. And that was the impetus for Dean Health Plan in particular to say, well, what's going on in our community? And since then, we've had this really robust partnership over the last several years, which we just were on a call this morning with another Medicaid HMO in a different county saying, well, how are you guys doing that? We want to do that too, right? And so our hope is that we will continue to have that ripple effect starting with Medicaid, because we know that over 50% of births in the United States are covered by Medicaid, but we do need those private insurance companies at the table because they have been missing. So I don't think they realize how much power they have to potentially shift this needle, particularly in our state as well.
Yeah, I think it's really important that you said that, because what I've noticed is this trend where a lot of the payers will wait to see what the reimbursement rate is going to look like from Medicaid. And it's like, that's not necessarily the way to go. Right. That's not the ideal model to follow, right? Because, there's certain limitations to doula Medicaid reimbursement. And so in talking about that, and some of the limitations and understanding that, what in your respective states have you found to be a good way to understand reimbursement rates, right? Some people are going fee for service, others are looking at global. What have you seen that is working within your respective areas? And Adriana, we'll start with you.
Yeah, I mean, the conversation around reimbursement, what that might look like, whether it be a global payment, whether it be fee for service, has been one that's been quite contentious, I think, with the Doula Partner Advisory Group and across the board has been very contentious. And here at the Department of Public Health, we aren't stewarding, I'll say, that the reimbursement rate that is entirely Mass Health's wheelhouse. And I know what they've done in part, there are a lot of listening sessions and are hearing from the doulas and the larger community and crafting their reimbursement rate based on the feedback and the things that they're gathering. So I'll leave that to that wheelhouse because it's a different and entirely separate wheelhouse. What I will say is that it's been immensely important that we are being responsive as a state agency, right? So it's not just taking in or listening, right? Listening and holding that information in, but listening and being responsive and being very transparent about what our what is in the realm of possibility for us as a state agency. Because at the end of the day, right, and I tell the DPAC this all the time, I will never sit here and make anyone a promise. I can't make you a promise. I will never make anyone a promise, or any group of people a promise, because they're ones to hold you to your word first and foremost. But also because this entire system is so they're so nuanced, and there's so many different aspects, right? That like this triggers this and this triggers that, and that might trigger something else in a different office. And so it would be unfair. It would just be unfair of me to make any promises. What I can say, and what I continue to do, is to raise and elevate the concerns, and whether that be around reimbursement rates, and what the reimbursement rate encompasses, right? So we're not just talking about paying someone for their service. We're talking about childcare. We're talking about parking. We're talking about continuing education. We're talking about capacity. We're talking about families. We're talking about things that are not just this pays for this. Absolutely not. And so how can we as a state agency kind of fan out and share those concerns and be responsive to our community as much as possible, so that everyone has the same information and that folks aren't making decisions and agencies. I will say that one of the things I'm really that's really heartening for me, and one thing that's really positive for me, is that there's been so much buy-in across different state agencies for this work and this initiative, right? We have our Massachusetts Association of Health Plans, which is representative of a large amount, I think a majority of the healthcare plans here in Massachusetts that have had their ear to the ground in terms of this work from its inception. And so they're listening, right? And though they may not say much in the meetings, right, or can't be very responsive in the moment, they're listening, they're asking questions, they're wanting to get more clarity. And so that and my hope is that, right, that those, making sure that the right ears are listening and that we're having these conversations in a wider forum, right? Let's not just have conversations behind closed doors. We're opening up the forum so that everyone is hearing the same information at the same time and can ask questions in real time, is offering a place in a space not only for the doulas to feel heard, but also that this information is not falling on deaf ears because we're being responsive. And so I'll share that. I'll stay with that.
Oh, good things, good things. All right. Twyla, this is for you and actually for all of you as we get ready to wrap up. Top 3 recommendations. And Twyla, I really want you to focus on, if you could just talk a little bit about data. The importance of it. Tia, if you could really talk about just understanding what it means to work in a rural community, top 3 recommendations for Medicaid doula reimbursement. And Adriana, coming from a public health perspective and understanding the bureaucracy within that space, what are the top 3 ways that doulas and CBOs can just leverage those relationships? So Twyla, let's start with you with the data.
No, I love that. So I think that one of the most important things is that as we're talking about reimbursement, as we're talking about, these data, the data doula collaboratives, I can't get out of my head, the doula collaboratives that are emerging in states, it's absolutely integral that there's money also going to pay for how we gather this information, because doula organizations and individual doulas don't necessarily have the bandwidth or the administrative dollars to set time aside to do robust data collection, right? And it must, and I mean this with a capital MUST, it must come from the community. This is not the kind of thing where someone can swoop in a parachute, and I come from academia, so I'm gonna say it out loud. You can't swoop in from the ivory tower, gather some information, and go back and measure it, right? Because you're missing so much information, and it's not being truly driven by where the work is actually happening. So fund it, right? Fund folks to do this work where they are in supporting their communities. Make sure that we're avoiding some of that swooping in and really being intentional about respecting that this information is coming from the people who are experts in it. We need more doulas. I'm not really doula, but I love data and measurement, and I know how important and valuable it will be in informing what the reimbursement rates are. So the third piece is making sure that the information that we're gathering is elevated and we get some wind behind us to get this moving forward so that it's influencing what the reimbursement rates are, right? This is not a mystery. We know that doulas are impactful, but I recognize that in some instances, having more of that qualitative and quantitative information around it, larger data sets, is going to be vitally important. One more thing, Chanel, people who are on here who run doula organizations, get in touch with Chanel and I about being a part of this consortium. I see other friends on here. I see that Amari's on here from Tulsa Birth Equity Initiative. She's a part of the consortium as well. Shout out Amari. But yeah, more people, more data, crowd sourced data, right? Stuff that's coming from our communities is super important. So those are my 4.
Yes, I keep talking data. You need the numbers. Tia.
Thank you for this question. It is interesting because Wisconsin is considered a more rural area, but what's interesting is our populations of color, particularly our Black populations, are concentrated in our more urban counties, who are in more proximity to each other. So when we have statewide legislative decisions being made, oftentimes those folks don't really understand those challenges and what's really happening, where we are seeing the most racial disparity in maternal and child health outcomes. So one thing we've done is really concentrate on local legislation at the county level and working with our champions. We were just asked to come to a press conference tomorrow that'll be more of a roundtable style versus your traditional press conference to talk about the rollout of the Reproductive Freedom Act. But I think really working with our champions, though, because we have such a diverse array of rural, urban, different perspectives, different communities, and really working with folks to not only do some of the research, Twyla, working with those doctors. We just got some of our published outcomes written into a 10-year report that comes out talking about the state of our Black community. And so I think really raising awareness around why is this important to everyone, regardless of rural or urban, because in true reality, we live in a country where it's the least safest place for anybody to give birth. And I think that's something we can all come together around. And so that's the challenge, is finding the right narrative here in Wisconsin, where we can get more bipartisan buy-in, where we can get more communities to come together. And in reality, our rural communities are suffering silently because of the narratives happening, right? We don't have as many providers in those areas. We've shut down particular hospitals or clinics after the pandemic or due to the pandemic. And so I actually think if we can change the narrative, and we were just talking about this in another panel that I was joining, is that how do we get away from that race-based approach as well, right? So that we're still not perpetuating the same sort of cycles, but how can we really come together with a collective narrative that we need to do better in general in respect to how we care for our birthing folks and our littlest members of our communities.
Thank you so much. That's very, very important. Adriana?
Yeah, I mean, it's hard to wrap it up in 3 points, but I'll try. And I think the first thing I would say is that we really need to be mindful that our healthcare system is not prepared for doulas as it currently stands, right? Like we're just not prepared. And so how can we leverage existing relationships within healthcare systems, outside of healthcare systems, in alignment with healthcare systems in order to prepare our healthcare systems, our providers, our clinicians, our social workers, those who are doing the work day to day, right? So outside of the birthing room, like you mentioned before, secretaries, the hospital staff, CNAs, all those folks need to have an understanding for and ultimately a respect for the field and the work and the autonomy of a doula. I think is important. That's the first. Second, leveraging existing relationships, right? So that might look like, a hospital association. That might look like healthcare plan associations. That might look like your local government, public health departments. It may look like the state health department, public health department. So leveraging those existing relationships, those bodies that are already standing. I think oftentimes it can be discouraging to ask a question and not get an answer, or ask a question and kind of be rerouted to someone else. Ultimately, this topic and the reason why we're having this conversation is because it is important. These conversations are happening, and we would, as a nation, right, we would be, and although where our maternal health rates are, it's very discouraging, but we would be negligent to not be engaging these conversations as state agencies. And so keep knocking on doors, keep asking the questions, ask again. And finally, I think centralizing the workforce would be an amazing asset and tool, right? And so no voice is too small, and no crowd is too big in order to affect change. And it's not about strong arming necessarily. It's about, centralizing, creating a voice that and a narrative that can be transferable, right? And that I can take the information you give me and I can give it to someone else and I can give it to someone else, and it's the same information and not all these different voices and different information and different desires kind of all swirling. So it's hard to prioritize as a state agency, right? You want something clear and concise that you can kind of take and run with, right? And I'm about to quote the Bible, but I'm not going to do that. But it's ultimately about, writing the vision, making it plain so that someone can run with it, whoever that might be. It might be a state agency, it might be a local organization, it might be a public health Medicaid office, it could be any one of those or all of them at the same time, but making the vision plain, making it concise, and making sure it's reflective of what your desires are and what you want for the workforce in order to ultimately affect change.
Yes, give thanks. I want to thank the three of you for being in conversation with me this afternoon. I greatly appreciate it. I think this conversation around doula Medicaid reimbursement is very nuanced. It's been happening for a multiple amount of years now. And there have been a lot of pitfalls in the nuances of the conversations, but this is a very hopeful and really turning the tides of what it really means to really center a community-based framework, to really understand what it means for hospital-based institutions and other institutions to work together, to really center a framework that works, and to understand that legislative policy is only one piece of the puzzle when we're really talking about addressing community-based issues, right? But also hold your legislators to task, right? And understanding that they too are accountable to you all as constituents as they are moving through those spaces. And so how are they showing up? How are they creating networks of support that are viable networks of support? and being able to create that sustainability that you all need so that you can do your work in effective ways. Because while we are having this conversation, babies are being born, children need to be centered, and folks who are pregnant are really wanting to know that someone genuinely cares about them. And so what we're really real basic, we're talking about someone's humanity, and we're talking about the collective humanity of all of us, right? And so the underlying, or what should be the overlying or arching mode through all of this as we're navigating in these spaces, is to really take a humble approach, but one that is also focused and direct on shifting that and really lifting up the individual and our collective humanity as we continue to do this work and center one another. So thank you very much. And Cynthia, I will hand it over to you.
Wow. The conversation was just so rich, and I really appreciate both the care and the thoughtfulness and the time that you've given. And I know that you guys give so much time to the field in addition to the families that you support. So thank you for this. I'm grateful for all of the folks who joined us in this conversation today. There were a lot of questions. Some of them may not have been able to be answered directly, but we will do our best to try to get that information to you. And I hope that you join me in thanking these amazing folks for the conversation we had. I wanted to make sure that you are aware of a few additional resources that we can provide from our center, both greater information about doulas in particular on the roadmap. If you want to read about the evidence itself, there is an evidence review. We have a checklist that states can use to help you to think through all of the different policy levers as you look to create a community-based doula program and support it. And then I also invite you to look for information coming out soon about a policy academy that we are planning to host here in Nashville in the spring, that will really focus on community-based doulas and try to get all of these questions that everyone has been asking answered, so that we can not only create the legislative changes that you all mentioned, but as you said, to really make it so that this is implemented in a way that centers the voice of those who really need this and includes the voice of doulas in creating and shaping these programs. So again, thank you for your time today. I encourage you to just fill out a very quick 2-question survey so that we can provide feedback to our wonderful panelists. And again, thank you so much for joining us today. Bye-bye.